biology department now because that was a little much. They got a great forestry department. I mean, they got the Duke forests that they, and so they and now they've got a really nice, it's a beautiful graduate school now of, I think it's environmental sciences and forestry, and it's gorgeous. They built this massive, there's a lot of resources being poured into that, green energy and sustainment.
When I was there, they hadn't yet built that new engineering complex.
Yes.
Behind the lighter colored stone. They just had the original. What it was called.
Just the reg brick. Yeah. Science Drive. Yeah. All my smartest friends were engineers. Just blew me away how much they could study and how smart they were. So we, it's truly. I mean, those guys were brilliant.
So we all set?
Thank you very much. Appreciate your help.
Do you need a laser pointer?
If you had one, let me see. I think he said it didn't work on the, let me see it. He says it doesn't work on the screen, which it doesn't. So I'll just go and, well, it's because of this.
Oh, yeah. There's lots
the glassy screens don't.
Reflexive different. They don't really.
I'll probably just blind myself if I have one.
It's a reflection. So we have a flat surface.
Yeah.
In fact, there's some danger with that because if the laser is reflected off the specular reflection surface, it's still coherent.
Oh, wow. Didn't know it. Blind somebody.
It's better to not.
Yeah. Well, a friend of mine, we were on a Boy Scout outing. He's another Scoutmaster, and we were up, we had one of those beautiful skies. We're watching it. It was during that Perseid meteor shower. And we were out there in lawn chairs in this camping environment, and he had this laser.
Yes, sir.
He could point up, and it would go all the way up. He could point out. It was a defined dot in space. It must have been one of these high-powered lasers or something. I mean, I don't know how far it went up, but he could actually outline the constellations. Oh, yeah.
It must have been like atmospheric wave,
Well, it wasn't so much a beam, but you could see the point. You could see the dot. It was really amazing. I was going to ask you about it, but my understanding is that might be illegal in this country. Like, you can't purchase this kind. I'm going to have to ask my buddy. Yeah, it was impressive. Yeah, you don't see anything, right? Nothing to reflect. Right. This was impressive. I mean, it was the coolest thing because he was led outward bound for years and years and years, and he said all they did during that time was study the sky, so he knew every star and planet. I had my little app. So I was able to say, yeah, you're right. You're right on this, because he knew the stars within the constellations, which was pretty impressive. Yeah, so.
So are people going to sit in the back again? I thought we saw
everybody up front.
Everyone sit in the front before.
It's harder to have a dialogue and discourse. Back there. Come on.
So that's so you're there starting salary. Well, yeah, I will keep them. So I will. Send you that.
Well, I just learned this morning what he's proposing is to teach an undergrad. that clock is what, 7 minutes?
Yeah, I've got about 4 after. So, yep. Sure. So where's Debus? Is he traveling? Debus, is he?
Yeah, he had to leave yesterday. I'm not sure where he went. Jackson. Today we have a guest speaker, Dr. Norris, Stephen Norris, excuse me. Dr. Stephen Norris, who is an orthopedic surgeon, and I just learned something about his background. He came to North Carolina to study biology at Duke University, and then he went to Vanderbilt University for the MD degree, and then he went to Emory for residency. And after that, Steve was in the Army, is that right? In Afghanistan, and as a medical officer there, saving soldiers during that golden hour when you can save them if they become for 2 tours of duty. So now Steve is one of the surgeons at Greensboro Orthopedics here in town, and has been gracious enough to come here and talk to us about one of his innovative surgical procedures that's becoming important for patients with shoulder problems.
Great. Well, thank you all for being here, and I want to thank Dr. Nisley and Dr. Pye for asking me to be here and share a little bit about a passion of mine with you. My first disclaimer is I'm not an engineer by background, so you don't have to worry about all those complex diagrams and force vector diagrams and all that. We're going to talk a little bit about a replacement that we use for certain shoulder conditions that's very new to this country. It's only been FDA approved in this country for a little over 10 years, which in our field in orthopedics is not very long. And so we'll go through, and I know that Dr. Nisley's got a quiz for you at the end. I'm going to try to help you along with that. I saw some of his questions, so I'm going to try to coach you a little bit on that. Exactly. So, but here's our learning objectives today, and I also want to say that feel free to raise your hand and ask questions during this talk. That will not throw me off, and actually enjoy kind of that back and forth conversation. So definitely if you have any questions as we go. But we're going to talk a little bit about the history of shoulder arthroplasty, the most frequent conditions that we use arthroplasty to take care of, some relevant shoulder anatomy. No medical talk is complete without that. A special problem of rotator cuff insufficiency, what it is and why it creates issues for us as shoulder surgeons. And then what is a reverse total shoulder replacement? And then who needs one? Who gets one? And finally, some, if we have time, pitfalls and complications in shoulder arthroplasty. So knowledge is knowing tomatoes are fruit, wisdom's not putting it in a fruit salad. So a little bit of knowledge. First of all, shoulder arthroplasty dates back to the end of the 19th century when a French surgeon, Dr. Pan, first developed a shoulder replacement. His shoulder replacement was designed to deal with a very specific patient with a very specific problem. And that patient had tuberculosis infection of the shoulder joint. And basically, it destroyed, as many bacterial infections do, destroyed the shoulder joint itself. So the patient was in pain. They couldn't use their arm. And he constructed the shoulder out of platinum and ebonite. And ebonite, as I understand, is a vulcanized rubber, so developed in the mid-1800s by Goodyear. But this is what it looked like, kind of interesting, but it was a constrained joint, so it was hinged, but did relieve the shoulder pain in that patient. Unfortunately, it had to be removed 2 years later due to recurrent infection, as you might imagine. So you go in an infected shoulder and put in an artificial part, and it's probably going to get infected. What did I do? There we go. So we'll fast forward about 50 years into the mid part of the 20th century, and Dr. Charles Neer, who's one of the fathers of shoulder surgery, developed the first modern humeral endoprosthesis. And his initial desire was to deal with a complicated problem that we didn't have good solutions for, which was shoulder fractures and dislocations. So somebody falls, breaks their shoulder, or the ball dislocates during that break. And the other conditions he used to treat this for was avascular necrosis. We'll talk about that in arthritis. But remember, shoulder fracture dislocation. Here's a couple of pictures of early design implants. They really didn't use it widespread in the U.S. until the late 60s and early 70s. But there was a 1951 design, really small stem, a monoblock, just one part. and this was made out of stainless steel. So it had reproducible results. Dr. Neer did some studies and proved that, and then it became mainstream really in the 70s. And then they added the socket, so replacing the socket side of the shoulder joint later in the 70s. Fast forward about 30 years into the late 1980s, and a surgeon in France developed the reverse shoulder placement, which we'll talk about. That's the majority of the talk today. And that was designed to deal with this rotator cuff arthropathy problem and failed arthroplasty. So what happens when a standard replacement fails? Well, you need something else, and we'll talk about why. It had some unique design characteristics. There had been some prior attempts at designing reverse shoulder arthroplasty with ball and socket type prosthesis, where you flip the ball and put the ball over on this side, the scapular side, and put the socket out here. But there were too many failures, and Dr. Grammont figured out that if you medialize the center of rotation, and the pointer won't work on this glass screen, but if you can medialize that center of rotation, and if you can lower the center of rotation, then you can tension the deltoid and develop a stable construct. So this was FDA approved in 2004. It was based upon Dr. Grammont's design. It was only initially available in certain investigational centers until we could get the numbers up in the U.S. to prove that it was efficacious and also safe for patients. And we performed the first one in Guilford County in 2009 at Moses Cone Hospital. That's not that long ago. So to be given a talk about something, we did the first one in 2009, it's kind of exciting for me personally. It's gaining more acceptance in the U.S. Its clinical indications, initially it was just failed replacements and rotator cuff tear arthropathy, and it's now been expanded. We'll talk about that later. And it's definitely, probably mostly responsible for the recent significant increase in total shoulder replacements in the U.S. Just to give you a rough idea, we're approaching 1 million artificial knee replacements and hip replacements in the U.S. every year, implanted into people. That's a lot of artificial joints. By contrast, between the late 90s and really early 2000s, we were only doing about 6,000 to 7,000 shoulder placements a year. We're just sort of on a different spectrum. But by 2011, roughly a decade or less than a decade later, we were already up into the 60,000s and probably approaching 100,000. So there's been this sort of astronomical increase in shoulder placements, and I would say it's largely due to the reverse shoulder placement, dealing with some difficult shoulder problems. So let's talk about surgical indications for replacements. One of the earliest ones, Dr. Neer, the reason why he started coming up with an idea of a replacement is shoulder fractures, high energy falls. We see a lot more of these now with ATVs and mountain bikes and motorcycles, and we're just seeing a lot more of these really high energy falls. The old shoulder fractures were trips and falls, and a lot of those patients could be treated conservatively. A sling, rest, some physical therapy once the bone began to heal, and the shoulder's pretty forgiving. So a lot of people could get away with a broken shoulder back in the day, but these days with the higher energy that these shoulders are absorbing, there's a lot more displacement of fracture fragments, and the options are definitely limited. Avascular necrosis is a condition where the blood flow to the ball of the head of the shoulder, we call that the humeral head, gets interrupted. And you can see on this x-ray right here, this area where there's some lucency. The x-ray beams kind of penetrate through it because there's really nothing there. And MRI shows a collapsing segment of dead bone. So that's avascular necrosis. That's another reason you might need a new ball. Shoulder arthritis, which is a condition where the cartilage in the joint, which is the bearing surface, wears out. So you lose that low friction bearing, and you've got friction and heat and everything else bad that goes along with that. So the joint wears out, patients hurt, and they lose range of motion. Failed arthroplasty, you can take a look at the gentleman there and tell something's not right. So the artificial ball's out of the socket and it's sticking up into nearly his ear. So that's another indication for a different type of replacement. And then finally, rotator cuff tear arthropathy. And in this series of pictures, you can see a swollen shoulder, so definitely bigger than she deserves. And then this ball is kind of snuck up out of the socket and into the up under the shoulder blade. I just did something I shouldn't do. Okay. So let's talk a little bit about shoulder anatomy. It's an amazing joint. A joint that can allow you to do that. I can't do that, but he can. That should be stressful. And then this, take a lot of impact, take stress, and it's an interesting joint that can handle those types of things. So it's 3 joints, really. The glenohumeral joint is the ball and socket joint of the shoulder between the humerus and the scapula. We then have the scapulothoracic joint. Essentially, the shoulder blade slides on the back of our rib cage, and so that's an additional joint in the shoulder. And then finally, the acromioclavicular joint, which is the one on top between the clavicle and the acromion. So really, 3 joints make up the shoulder. It's a joint that's inherently unstable, thankfully. That allows me to scratch my back. If I had a stable joint like my hip, I couldn't do that. So it's a very unique joint in the body. I like to really think of, and a lot of shoulder surgeons think of the balancing act that occurs between the ball and the socket as the seal and ball. My scapula is kind of moving with all those scapular stabilizers to keep that ball in proper position. So it's really it's remarkable. And it does have the greatest range of motion in the body. Glad I can't do that. So a little bit about the bones. We've got the humerus, that's the arm bone. We've got the scapula, which has the glenoid. That's the socket portion of the scapula. And then we have the acromion, which is the bony part that you can feel if you reach around on the top of your shoulder. That's the attachment point for the deltoid muscle, which is the arm elevator. The muscles, we talked about the deltoid. Its chief job is to elevate our arm. I'd pay attention to this slide in terms of the next couple slides with these muscles. You might see something about that later. So the deltoid muscle is an arm elevator. The rotator cuff muscles are the next layer deeper than that, and that's a series of 4 muscles that arise from the scapula. They attach on the humerus, and their job is to keep that ball centered on the socket. So they're kind of that seal, helping keep that ball on top of its nose. And then finally, and this shows a little bit about the force vector. So the resulting action of the supraspinatus is a humeral head compression. It's compressing the humeral head against the glenoid surface there and holding it in place. And finally, the scapula stabilizers, which are numerous muscles around the shoulder blade that keep the shoulder blade stable against the thorax. So trapezius, rhomboid, serratus, there's a number of them, but it's a muscle group. So we've talked about the history, conditions that frequently require arthroplasty, relevant shoulder anatomy. Let's do a little quiz. This will help you for later. So in what country was the shoulder replacement first developed? France. Perfect. And Dr. Neer, father of the modern shoulder replacement, first used his device to treat primarily what shoulder condition? Fractures and dislocations. So breaks and dislocations. Good job. All of the following are current indications for shoulder replacement except shoulder arthritis, active shoulder infection, rotator cuff tear arthropathy, or failed shoulder arthroplasty. What would we not put one in for? Active shoulder infection. That's destined to be a failure. Good job. True or false, the shoulder is an inherently unstable joint that relies on a delicate balance of muscle forces to allow for normal function. True. Great. I like that one. Clear conscience is a sign of a fuzzy memory. Okay, so let's briefly talk about the standard shoulder replacement so you've got a framework on which to put the reverse and understand what the difference is between the two. So the standard replacement is simply resurfacing the worn out joint. So we're putting a metal ball where the cartilage ball was before, and we're putting a plastic socket where the cartilage socket was before. So we're just creating a new surface. You see the long metal part that goes down the bone on the inside, and all that is simply a mount for that polished ball to go on top of. So that's called the stem. That goes inside the bone and stabilizes itself in the bone, either with cement, grout, or just with a press fit. So what are some considerations for it? Well, we typically do that replacement for somebody who has severe shoulder pain due to arthritis. This wouldn't be our first option. We would want to do medicines, shots, cortisone shots, things like that before we recommend a replacement. It's the last option, option Z. It's a technically demanding surgery. It's very difficult. It's a lot more difficult, in my opinion, than a knee replacement. I do both. It's a lot harder. It's around tiger country, big nerves, big blood vessels. Bad things can happen deep inside your chest. So it is tough. But it does produce good, reproducibly good and excellent results. So patients have better range of motion, much better pain, and better function with a shoulder replacement. But if you look at that last one, this is what we're going to talk about. It requires an intact or repairable rotator cuff. So I typically get MRIs on all my patients before we schedule rotator cuff, or a replacement to make sure that the rotator cuff is okay because of what we talked about. So the rotator cuff, let's talk a little bit about insufficiency. The rotator cuff and deltoid work as a force couple. So the deltoid's the arm elevator, the rotator cuff is the humeral depressor and compressor. So they work together, and when they're not working together, the shoulder doesn't move very well. In fact, if you've ever seen somebody that goes out to shake your hand and the first thing you see is their shoulder shrug up, they probably have a rotator cuff problem. You get a loss of fixed fulcrum mechanics if you take an x-ray and you look at a shoulder that's actively moving. Typically, it doesn't matter whether I have nothing in my hand or a 5 or 10 pound weight and I elevate my arm. It's remarkable, but that center of rotation of the humerus where it rotates stays fixed. It's amazing to watch that, despite that flat little socket that doesn't provide a lot of support for it. So this is a person trying to elevate their arm that has a rotator cuff problem. So you can see they shrug their shoulder, they don't get their arm elevated very well, so you have this muscle imbalance within the shoulder girdle. It leads to progressive joint wear and cartilage loss and significant functional impairment. Cartilage does a really good job in terms of its durability if it's subjected to primarily compressive forces. It does not do very well when subjected to shear forces. And what you have when you have a no cuff is you've got this up and down where that ball is sliding up and down on that socket, and that's a lot of shear. And so that's one of the things that leads to the arthritis. Here's a replacement with no cuff, and you can see the metal ball is nowhere near. This is a marker for the socket. You can almost see the outline of the plastic socket in there, and it's not even working. So this is a big problem for a shoulder placement, and they get poor arm elevation. You also get uneven loads. This is a side view where we're kind of lifting the arm out to the side and shooting through the shoulder. This is the front, and this is the back. And what we can see is that this ball is off the back. Here's the center marker, and the ball is completely set off the back. So you get this rocking horse effect where it just rocks the component loose. So if you do not have an intact rotator cuff, you really cannot perform a standard shoulder placement. So what are our options? Prior to Dr. Gromont's design coming out in European experience, we had no real good options. Our best option that was developed in the U.S. by some U.S. surgeons was essentially accepting that your ball is going to ride high and go up under your shoulder blade, up under the bone. And so extending the radius of curvature of the ball, you can see this particular ball is not a hemisphere. It actually is an extended hemisphere. So there's that extra metal over the top that would allow for that metal to glide up under that shoulder blade. So you're accepting that the ball's not really going to articulate in the socket anymore. It's going to be kind of constrained within this area, but it's going to basically come up and bang up against the shoulder blade. So you've got metal on bone, that hurts. So my experience with this, and I did quite a few of these back when that was our only option, was the patients were better, but they weren't great. So we didn't have a really good option. So what is this reverse total shoulder arthroplasty thing? So I like this one. You don't need a parachute to skydive. You just need it to skydive twice. So what is a reverse shoulder placement and who gets one? What is it? Well, first of all, it's a total shoulder. Total shoulder refers to a arthroplasty that deals with both sides of the joint, the socket side and the ball side. So it does replace both sides of the joint. It's a semi-constrained shoulder arthroplasty. So a conventional shoulder placement and our shoulder, the way we're born, is an unconstrained joint. It really has no bony constraint. It's allowed to go anywhere that these muscles can take it. But this actually has constraint. We'll talk about why it has constraint in a minute. And then a fully constrained joint would be like that first replacement that Dr. Pian in France designed, where it's hinged. That's a fully constrained joint. So it's a modular device that consists of components. The metaglin is, and I wish I could point to you guys. I don't know if anybody can see it, but this is the metaglin, which is a base plate. It's a mounting plate. We then have the glenosphere, which mounts onto the metaglin. We have a stem that goes down the inside of the bone. And then we have, finally, this polyethylene liner. And those are the four components of reverse replacement. So what are some design considerations? I'm an end user. I use what you guys develop in the lab and in the engineering department in school and in the industry. But what would you be thinking about as engineers about trying to come up with something? Well, first of all, you've got to have durable materials. This isn't something you want to be dissolvable. You want this to be around as long as that patient is around. So we want durable materials. We don't want something that's going to either get electrolysis or corrode or who knows. It also needs to be flexible. It needs to be designed for various uses. We talked about reverse shoulders were initially designed just for failed shoulders and rotator cuff tear arthropathy. Well, now we use it for a lot of things. So you need something with adaptable uses, and we'll talk about that. We need to be able to do revision surgery on failed surgeries. We need to deal with severe deformity, as a lot of these shoulders have awful bone loss and severe deformity. We also need to have a stable implant. So durable materials, flexible uses, stable implant. We want to decrease that stress, medialize that center of rotation, lower that center of rotation to tension my deltoid and give me better arm elevation. But all of that really decreases the stress on the mounting of that hardware. Sir?
We talked about the materials.
Yes.
So what kind of testing would you recommend for making sure it's compatible with the body, so that you don't put something toxic in it?
Exactly. So fortunately, there's been metal used in the human body for a long time, dating back to the late 19th century. So there's some good historical data regarding what types of materials do well. Stainless steel, of course, one of the longer running ones we've used for implants. Titanium has had a long run. Hydroxyapatite, one of the things we'll talk about in a little bit. They're alloys, cobalt chrome alloys we use, aluminum is used. We were just talking, Dr. Nisley and I, about magnesium being a potential option as well. So, you definitely would have to do in vivo testing. You can do only so much on an Instron machine, and then you got to take it actually and put it in probably an animal first and make sure it's not going to fall apart or be toxic to the animal. But those are great questions. They found with some of these hip replacement recalls, have you all heard about that? So they found there was some wear that was noticed in humans that was not noticed in the lab. That if you had certain positioning of the implant, that you could get some of the metal-on-metal bearings, which were coming out. We thought metal-on-metal with the improved engineering and improved manufacturing processes, that we could create such fine tolerances that bearing would be a safe bearing and it could last forever, right? Metal-on-metal, that's not going to wear. Well, what we found is that we would get these edge loading, and then we would start to get metal ions in the body that were unhealthy for people. So they're actually, have recalled some of those implants, have had to do ion testing in people's bodies to look at some of these metal ions, because above a certain level, it's dangerous.
So excuse me.
Sure.
Which kind of alloys are used at present?
So titanium alloys are used right now, and cobalt chrome and stainless steel alloys are the primary ones that I work with. And there is probably an exhaustive list somewhere that I'm not privy to, but those are the ones that I use on a regular basis. 316L stainless steel alloys. We also have the titanium alloys that I'll talk about in a minute, and then the cobalt chrome is a metal alloy that we use because it's highly polished. It's a hard metal, and we can get a really high sheen on it and low friction. So there's all kinds of ceramics. I mean, ceramics is a huge thing with bearing surfaces now. Very hard, but somewhat brittle, and they've fixed some of those things. So metals and biomaterials is a huge field that you guys are getting into, and it's going to be big. So let's talk about those metals. So titanium, the things we like about titanium is, number one, it's very, very strong. Number two, it's very, very light. So if you start putting pieces of metal in people's bodies and it's all stainless steel, it's heavy. And this particular implant, titanium, is quite light. You pick it up and it's just it's a few ounces. It's not very much, but it's quite strong and durable. The cobalt chrome is this metal ball. So this is the glenosphere right here. So this device actually is polished to such a high sheen that the friction coefficient is quite low, and that's what we want. We don't want to be generating a lot of friction on the plastic. The hydroxyapatite is the white stuff on that stem that you see, and that's actually applied in a manufacturing process directly to the metal. So it's connected to the metal, and then what HA does, hydroxyapatite, is actually induces bone growth onto this implant. So we put the implant in without a grout. The bone is basically pressed into a shape that this thing is designed to fit into, and then we drive it in with a mallet, with a hammer basically. And it wedges itself in the bone, which gives a little bit and then grabs it. And then over the course of about 10 weeks, bone will actually grow onto the surface of this implant. And then finally, the highly cross-linked polyethylene. It's a plastic, like Teflon. And there have been different manufacturing processes, molding and ram extrusion, and then they treat the plastics for, to try to make it stronger. But this ultra-high molecular weight, highly cross-linked polyethylene is extremely durable plastic. And in hip replacement models and simulators, we think it'll last 30 years. And that's load bearing. So we hope on the shoulder it'll do even better than that, because we don't load bear and walk on our shoulders. Sir?
Does that polyethylene ever wear out? And
It does.
So you can do a minimal procedure or something?
Yeah, so if you follow this implant and you track it and you see evidence of poly wear, theoretically you could go and put a new plastic in and you're back in business. Don't have to do anything to the metal. The problem is when this poly wears, it creates these microscopic fragments of that polyethylene, and the body sees that as a foreign material and doesn't like it. And so it starts sending its own immune system after those fragments. So macrophages and phagocytes will actually go and gobble this thing up and then start secreting things that unfortunately damage bone. And so you wind up sometimes having soft tissue damage or bone damage. The same with those metal ions we talked about. Some of that metal debris that was developed, that was starting to form around these hip replacements, our body would then attack that, and you just lose huge amounts of soft tissue, muscle, and bone. And so that, unfortunately, that plastic as it wears is not totally benign. So what are some of these other, we talked about the materials we make it out of. They've got to be durable. They've got to be flexible for different uses. What about the design itself? Well, we definitely need flexibility in the design for the reverse shoulder. We have both press fit and cemented options. In very poor quality bone, I'll actually use a little grout to stabilize the implant. I don't want my implant coming loose. As that patient starts to love her knee shoulder, I don't want her to lift up, and next thing we know is that stem is loose. So we'll sometimes put a little grout in, and that's polymethyl methacrylate is what we use for that. Sets up in about 8 to 15 minutes, depending on the type of polymethyl methacrylate. We can mix antibiotics in that will elute over a long period of time if we're concerned about an infection case. But so we can do either cemented or press fit, like we talked about. Just push it in the bone. There's also screw fixation on the scapular side. So the back side of that base plate actually has HA on it. So bone will grow to that, but that takes 10 weeks. Well, during that time, that implant's going to be subjected to some stress. And so to deal with that, we actually fix this thing to the bone with screws. And these screws are actually locking screws. So they go into the bone, and there's a separate locking mechanism that we tension at the very end that actually locks those screws into the plate. So it creates fixed angles, which with engineers, that's a really strong construct, those fixed angle screws versus just compression fit. We also have various sizes and offsets, so I can match the anatomy of the patient that we have. So we'll go in and obviously sometimes we'll know we've got a really small patient, we need to use our smaller implants, or a really large patient. We've got to be able to adjust for the size of the patient. And then finally, a modular construction. So these particular third-generation reverse replacements, we can convert back to a regular replacement. So if that scapular side fails or they have a fracture and we have to convert back to just a big hemiarthroplasty or just a partial replacement, I can actually convert that stem, take the top off, put a modular portion to the top of it, and then mount a ball back on it. So we can flip it back around. Yes, sir?
With PMMA, I remember earlier studies, there was some concern about the thermal coming
Yes.
off. Is that still something that we're concerned with?
Big time.
Okay.
So you put a lot of PMMA in bone, it's going to kill bone because as it heats up, as it sets up, it generates a lot of heat. And as a shoulder surgeon, I really don't like methyl methacrylate because it kills bone, especially in yes,
the heat of polymerization.
That's right, and it'll necrose bone. And that was one of the big problems with initial socket designs on shoulder replacements, is they grouted in a big keel. So you'd basically ream that socket to put a new socket in, but the design was a keel design that was cemented. So you'd punch a keel hole in there, you'd stick a bunch of cement in there, pound this thing in, and guess what? That temperature would go through the roof and kill all that bone, and then everything would loosen up. So we almost use the cement. I almost always use a cementless application for shoulder replacements, or very little.
So in vitro studies with PMMA, the cells all did survive very well, right? I mean, there was no problem with the bone cells or osteo.
It depends on the heat, and again, if you can just diffuse the heat. So we do things to diffuse the heat when we use methyl methacrylate. They do venting things to try to vent the pressure because it generates heat and pressure, and sometimes can cause embolization of fat and bone marrow to the lungs. I mean, there's all kinds of issues with methyl methacrylate, and so we have safety concerns that we have during surgery. We want to make sure that patient's well hydrated. We want to make sure that the area is vented. We want to use irrigation, which is cold irrigation, to try to decrease the temperature. It's not as big of a concern in the longer bone and the bigger bone like the femur, but it definitely is on the socket side, the glenoid side. But they did testing on it, and we sort of know what the problem is with it, and we just work around those problems. They've done some different methyl methacrylates that are a little bit slower setting up and don't have that extreme heat, but all of them get hot as a part of that polymerization process. So this is a really interesting picture. So this is a scanning electron microscopy picture of a particular design. This is a porous coated design where you can see the bone. So the white is the metal, and they create pore sizes that are similar to the pores that are naturally found in bone. And so what will happen is bone will actually grow into these pores. It'll be induced to grow into these pores. It likes those spaces and wants to get in there. So you can either have an HA coating on the surface, or you can actually do a porous coating where it's just metal, there's no HA, but the metal has these pores that the bone grows into. So I think this is amazing. So the gray in that is actually the bone. You can see the little bone channels and everything in there. So I love that picture. But once that bone grows in, and Dr. Knisley was talking to me about that yesterday, it's there forever. I mean, you can't get it out unless you chisel it out. So that's another option for fixation as well. So we want a stable implant. We want one that's got flexible design, flexible uses, and we want durable materials. We want it to be around forever. So just remember those three things. So who gets one of these things? Well, definitely the guy on the right there, or the fellow in the picture gets one, because he's got a shoulder that's escaped. That ball is up under his skin. It's not really constrained under the shoulder blade anymore. He's got a very, very unstable situation and can't do anything with that arm. And for elderly people, this is a difference between them staying at the house or going to a nursing home. When you've got something like this, you can't do anything to help yourself. So it can be an independence thing for the elderly. Rotator cuff tear arthropathy, failed shoulder placements, failed shoulder fracture surgery, and then severe fractures in the elderly. Remember who we don't use it on? Infected people. Just remember that. Oh, and not this person either. So she's got shoulder pain. Why wouldn't I use a shoulder placement, a reverse shoulder placement on her? Unless somebody really wanted me to. She's going to wear it out. For sure. She will absolutely wear that shoulder placement out, and she'll be wondering what's the next step when she's 50, and then the next step when she's 70, and it just won't last. So it's really contraindicated in young people. So what does it require? What does that reverse require? It requires a functional deltoid muscle. Just one look at that fellow's shoulder, and it doesn't look right, does it? So his whole posterior deltoid is missing. So he's had some type of neurogenic injury. I can see a shoulder scar. Somebody might have damaged his nerve by sticking an arthroscope or something through it, but he's missing the back of his deltoid. He would not do well. That's the arm elevator. We create that fixed hinge with that reverse shoulder, put the ball over here, let the socket hinge on that. Well, if I don't have the arm elevator, it's not going to work too well. It does require adequate bony support on the glenoid side. Sometimes we have enough erosion that there's no bone there. That socket's worn away, especially in rheumatoid patients where you get that inflammatory destructive process in the joint. And I have had patients where I can't do a reverse, and I hate it. I did one on his left side. Guy did great. Came in debilitating pain, constantly hemorrhaging from his shoulder because it's the destructive process. And we got CT scans and other things to look at the bone. He had no bone. We can't make bone where there is no bone there. So you might think about some type of metal cage or construct something to give us support for it, but it really wouldn't work. It's a great option in a low-demand elderly person. That's the perfect person for it. And it's definitely for people who rely on shoulder balance and mobility. So this is probably the most important reason why I like a reverse shoulder for the elderly is it doesn't really require rehab. You tell that to somebody who's been through a prior shoulder rotator cuff surgery, and they're just like, really? I don't have to go to therapy? And they don't. We just turn them loose and say, start using your shoulder. It's strong enough, it's durable enough to let them just start using it right away. It's definitely contraindicated in active infection. It can dislocate, and it does look funny. The reason why it looks funny is you medialize the shoulder center of rotation, and you've dropped it a little bit, so their shoulder looks a little flat. It doesn't have that roundness to it because, again, I've got a ball up under that deltoid that makes it look like it's got that nice round. So when you move the ball over here and you put the socket over here and you lower that and medialize the center of rotation, it looks flat. So I always tell the ladies definitely it's going to look a little funny and your bra strap may fall off, but they're good with that as long as their shoulder doesn't hurt and they can use it. So a little bit quickly through the technique. You guys may not care about this stuff, but we do it semi-sitting, general anesthesia for everybody in a block where we numb their arm for about 18 to 24 hours so they don't hurt when they wake up. Definitely need an assistant. Beach chair position, we talked about that. Delta pectoral, so we go between the deltoid muscle and the pectoralis muscle. That's an inner nervous plane, different nerves. And so it's an easy plane to get into. We cut the ball off. We then ream down the place for the stem. We broach the stem. I typically use press fit, but cement if the bone's bad. And I like to get a stem in there to protect the bone too. Their bone's usually so poor that if we're not protecting that during the rest of the surgery to mount the ball over on the socket side, it'll destroy the humerus, just putting instruments in and out. So we try to get a stem in there to protect it. We'll then sublux the humerus. We'll slide it to the back, away from us, and that'll show us the socket, and then we'll work on the socket. So we'll ream that. We put a guide pin in and then ream it with reamers, and then we place our Metaglin. That's one on the bottom with some screws. We do our glenosphere trial, and this is actually one of my patients. That's what it looks like. So you can see where that ball is mounted on the very lower part of that scapula. You want it as low as possible. And then you can see the implant pressed into the bone there. The hollow part, the area that you see that's a little lighter, is actually where that plastic is mounted. So the piece you can't see on this x-ray is the plastic. But there's actually a plastic socket that's precisely sized to match the radius of curvature of the ball there. So here it is. It's 1 or 2 nights in the hospital, most 1. Occasionally some rehab, but not usually, just a little bit in the hospital. They go in immediate activities of daily living. That's ADLs. I do limit weight bearing. I don't let them push out of a chair for about 10 weeks, and that's to let that bone on growth, that bone growing onto that HA coating occur. If they're constantly leveraging their whole body weight on that implant, I'm concerned that micromotion is going to cause that HA bonding not to occur. But no formal therapy. They can use a walker. They don't need to wear a sling. They can return to sports in 3 months. I've got patients swimming, playing golf, tennis, not ATP tennis, but they're out there. So what bad things can happen, and then we'll open it up for questions. How am I doing for time? Doing okay?
8 more minutes.
Okay, good. So one of the big concerns I had when the reverse shoulder came out was complications. One of the guys that I worked with that I had a lot of respect for, who was at Duke initially, now is in Seattle, Washington, was on the investigative panel for reverse shoulder placements. Their initial published complication rate was 25 to 50%. That's U.S. world shoulder experts doing this operation. They had a 25 to 50% major complication rate. I was like, I don't want any part of that in Greensboro. No, thank you. So they worked out some of the design issues and some of the indications and who should get it and who shouldn't. And now that complication rate is much, much lower. We're down in the probably sub 10% range for major complications. The primary complications being dislocation, infection, and loosening. So we said it's semi-constrained. It's not fully constrained. It's not a linked hinge joint. That socket still needs to stay on the ball, and we're relying on the muscle balancing and tensioning of the implant. That's my job, to get it in so it's tight and stable and all that. But it can come dislocated. It can come out. And I tell patients about that as a potential complication. If that happens, sometimes we have to go back to surgery, open that incision up, go in and put in a bigger poly, a tighter plastic insert. I've never had to revise the metal, but occasionally we've had to put in a tighter plastic to make it stable. Infection, a lot of these patients we're doing this operation on have had multiple surgeries. They've had rotator cuff surgeries, they've had scopes, they've had maybe a shoulder replacement. And because of that, there's a higher infection risk in a person who's had a prior surgery. We'll go in and find loose screws and loose anchors and suture, and all that stuff is a little harbor for bacteria. So infection rate for revision surgery is definitely a real deal. And then loosening, this is a picture of probably infection, I would say. Significant swelling. You can see the dark areas around the implant itself. That looks like fluid and swelling. You can see the broken screws. That's just, there's nothing good about that X-ray right there. So that's not mine. And then there's some other concerns. There's really no long-term data, and I tell every patient that I counsel for this surgery, we don't know how long this will last. We truly don't. The European studies are getting out to 15 years, closing in on 20-year studies. The survivorship looks pretty good. I say pretty good, probably 50 to 75% survivorship at 15 years. That was with the initial designs. I think the newer designs have solved some problems that I think have led to failures. So my suspicion is these will probably last 20 years. I doubt much longer than that. Probably the plastic, as you talked about, nicely. So we're concerned about the durability. Younger patients, how much abuse can this take? There's limited bailout options. We talked about being able to go in and take out the ball, turn that thing on this humerus side back into a ball over there. So that's really our only bailout option, or resecting the whole thing, taking it out, which we would have to do for infection. And we definitely know that there's going to be an increased revision burden. So 60 to 70,000 of these done in the U.S. each year. Well, that'll be 100,000, in 5 years, and that'll be 200,000 in 10 years. And that means there's going to be a lot of these walking around that eventually are going to wear out and need to be dealt with and revised. So that'll be for future surgeons, probably. So true or false, a reverse total shoulder replacement requires an intact cuff for proper postoperative shoulder function. Reverse shoulder. Do they need a cuff or not? They do not. And the reason they don't is because we've created that semi-constrained joint. We've recreated a fixed fulcrum mechanics by fixing that ball now on the scapular side, and that socket will rotate on that ball. So they do not need a intact rotator cuff. So that's false. Which of the following are current indications for reverse shoulder placement? Rotator cuff tear arthropathy, shoulder instability following an arthroplasty. That was that one where that thing was stuck up in the guy's ear. Shoulder fractures in the elderly with poor pre-injury function, or all of the above? All of them. Those are all great options. True or false? Active infection and neurologic injury resulting in poor deltoid function are absolute contraindications for reverse shoulder placement. So active infection, do we want to put a metal and plastic in there? No. That's true. And if they've got neurologic injury like that one fellow had and he didn't have a deltoid, well, he doesn't have the ability to lift his arm up. True or false? Thanks to a plethora of long-term studies, surgeons are able to guarantee patients 20-year survival for the reverse shoulder placements. False. We have no idea how long they're going to last. I can tell you that The individual had his first shoulder replacement here in Greensboro in 2009. It's still working. So I can tell you, it's 7 years right now. So a couple things just to think about it. If you're considering this, number one, wrong patient. Don't do it on the wrong patient. Unrealistic expectations. Wrong implant. You got to have cuff integrity if you're going to put in the standard shoulder replacement. Infections. Watch out for revision cases. The elderly are probably the best people that need this replacement. They're also the people that are going to fall right after your surgery and break their humerus. I've only had that happen on one of my patients. Fortunately, the stem was stable. She gave it 6 weeks before she fell, so her stem was still stable. She broke it right below the stem. We just put a brace on her, and it healed up on its own, so we didn't have to go back in, thankfully. And then we got to think about dislocation due to the reverse shoulder replacement, that unique design that allows for that thing to pop out. So we covered the history, conditions, fractures, dislocations, failed arthroplasty, rotator cuff insufficiency. We talked about anatomy. Remember your deltoid. Remember your Scapular Stabilizers and your rotator cuff. Those are the three groups, not the distractors that Dr. Nisley will put on your little thing. We talked about the problem with insufficiency is you don't have that ability to maintain that fixed center of the ball in the socket, so that you got to do something different. You got to change the mechanics up and flip the ball around. We talked about what it is, who gets one, the pitfalls and complications. I'll just leave you with these thoughts. Number one is it's definitely an evolving field, and you guys are a big part of that. The materials engineering, the designs that are coming out now are improved, mostly. The number of these replacements is increasing dramatically each year, and reverse replacements gaining acceptance in the U.S., and I would say it's actually last year it outnumbers standard replacements. So we're doing more reverses than we are the other ones. But we don't know anything about the long-term survival. So we're a big question mark about where these are going. So experience is something you don't get until just after you need it. That fellow's had a bad day at the boat ramp, for sure. Any questions? So thank you for your attention. So let me tell you about one little quick thing that's come out that we're not sure about, but it's probably metals folks and engineering people looking at ways to try to minimize the size of the implants that we're putting in and preserving bone. So one of the things that's just come out probably in the last 5 years is small stem humeral components. So instead of putting that stem 7.5 inches down the arm to here, trying to make a smaller stem, because we really haven't had a lot of loosening problems on the humeral side. And the early studies that came out initially looked pretty good, and the FDA approved it. And I can tell you right now they're having some problems with those stems, either being put in incorrectly because you don't have the conformity of having to go all the way down through the narrow isthmus portion of the humerus. So some of them are going in a little crooked, and they're also having some that have become loose. So just because there's a new design doesn't necessarily mean it's a great thing. I think sometimes I think it's great to have these innovative designs. I think it's good to study them. I personally like to wait for those to kind of go around the carousel a couple times before I jump onto it. Just the way I am. I touch the water first before I jump in. So, sir.
Thank you for that presentation. Really enjoyed that. What's your opinion on like the kinematics or the range of motion? excuse me, in your patients post-op? And then when you're dealing with an arthritis patient and you have kind of this progression, maybe from wrist to elbow to shoulder or vice versa. Does that change kind of your approach when you're doing it?
Great question. So first question was, what's my opinion of the kinematics of reverse shoulder placement? It's an excellent question. It is definitely not normal kinematics. If you see somebody elevate their arm with the reverse shoulder, you can usually tell there's something not quite right about it. They tend to have a little bit more of a marionette, like their arms being picked up. And that's due to the loss of those rotator cuff muscles, the external rotators. Most of them don't have that. So they can elevate well their deltoid, but they don't have that great ability to get their hand back here. Some of them can, but it's definitely a little bit of a different kinematics, but it's fixed fulcrum. So it is a smooth elevation versus the person that has the rotator cuff deficient shoulder where they're shrugging up to get their, and then they're kind of throwing their arm up or they're taking their other arm to lift it up. So it restores shoulder kinematics to the point where it's functional, but definitely not normal kinematics. There's something beautiful about watching somebody elevate their arm that has normal kinematics, and there's nothing too beautiful about that reverse. They just kind of get it up there, but they don't hurt. The biggest reason to do it is not for regaining range of motion overhead, it's for pain control. That's what I tell patients all the time. As far as considerations for other body parts that might be arthritic, that's a great question. I'll always examine their other shoulder. because we're getting ready to take one of them and do something pretty big to it, and obviously bad things can happen to that. So I want to make sure they can do something with their other shoulder, and I definitely check the elbow and the wrist to make sure there's no major issues there. I wouldn't want to do the reverse and have an unstable elbow because of bad rheumatoid arthritis. I probably have them see my elbow partner first and talk about who should go first and what needs to be done. But that's great, because usually if they got disease here, they've got it somewhere else too. It's a good question.
Do you ever have a patient who requires both shoulders?
Yes. Yep. In fact, usually when they get that first one, they love it so much and the pain's gone and they can't believe what they can do with it. They often will kind of almost rush to that second one. I usually make them wait at least 3 months through that biological healing time, to where I know that implant is stable within the body. But one of the concerns is the patients that get the reverses don't do great behind their back. They typically can get here and they can get here and pretty good function, but they usually don't have great internal rotation, ability to get back here. And so I have a patient now that can't quite get back here. She wants her other one done desperately, and I'm actually thinking about changing the rotation on her humeral component to try to give her a little bit better back here. Otherwise, she can't get back there at all. And that's not good. You can't get behind your back to take care of the bathroom time. Yes?
I have a question in regard to your opinion. You have heard so much about 3D bioprinting and all these. How do you see that in your...
It's already being used for custom implants for patients. So I think it's going to be huge, personally. I don't know enough about the engineering. What's that?
Are you using any over here?
We're not. I know they're investigating it and doing it, and I know for certain specialized implants, and I believe for some tumor surgeries where patients have, loss of a whole part of their arm or leg, they're doing some 3D because they'll get accurate imaging of the body part, and then they can go and do some 3D construction. I think they'll be able to use some really lightweight composites that would make replacing long sections of bone or body parts, doable, because typically you'd put in stainless steel and titanium, and that stuff for like a total humerus or a total femur is heavy. And like in a pediatric patient that might be dealing with pediatric cancer, that's hard on them, for ambulating, being able to get up and move on it. So I think they're working on it, and my suspicion is that'll be probably the next big frontier would be 3D printing of orthopedic parts, because you can get exactly what you need. You don't have to pick from a pan and say, well, small, medium, and large. I can say I want it for Joe or Sally, and make it exactly the right size.
What kind of medical options are there if infection is prone?
So if you catch the infection early and it's a superficial infection, we can treat with antibiotics. So that's the first medical option, is antibiotic treatment. If the infection is established, meaning it gets set up in there and it's in direct contact with the implant, the artificial replacement, it's got to come out. These bacteria typically will form a kind of a protective coating around themselves that's a slimy coating, and it's really resistant to being able to just wash it off. And so most of the times that we have an established infection, we actually have to remove the implant. We'll then place an antibiotic spacer that it's a polymethyl methacrylate type of a spacer that's designed to hold the place for that replacement. And it also has antibiotics in it that elutes into the bloodstream, so you get really high local tissue concentrations of antibiotic to kill the bacteria. And then typically after 6 weeks to 3 months, we would then go back in and implant. We do some testing in surgery, look at some frozen sections of the tissue to make sure there's no evidence of ongoing infection, and then reimplant. That's a great question. So typically it's a staged revision. You have to go in. Yeah.
Why would a person get an infection? I can imagine if the procedure wasn't sterile, they would get an infection. But let's say the procedure was perfect, and then they get an infection a long time later. Why would that happen?
So the question is, why would somebody potentially develop an infection? Let's say you didn't get one in surgery. There's a lot of opportunity in surgery for one. Breach and sterile technique. We're cutting through pores. Each of the pores has bacteria in these pores. So you can clean the skin all you want, but if there's bacteria sitting in a hair follicle or pore, that then gets in the wound. So we're washing things out. We're giving antibiotics intravenously during surgery. We do a lot of things to prevent it, but surgical site infections, unfortunately, it's still a real number. But let's say it's 2 years later and they develop an infection. How can that occur? Typically, it's through seeding from another part of the body. So a heart valve has a has a little infection on it, or somebody gets a bladder infection and it gets into the bloodstream because it's a raging infection, or a bad cut that gets infected. So we tell people, once you have an artificial replacement, and you got to be really careful about infections. You try to get on antibiotics right away. You don't want some just infection to go unabated in the body. Well, I appreciate your time. You guys were great. Thank you for all the good questions, and thank you for designing all the stuff we're putting in.
So thank you,
Appreciate
Dr. Norris. That was a very informative and So I passed out the quiz, so everyone can take the quiz.
I'm about to say, your last question don't make no sense. It's supposed to be station.
Let me see here.
Nice to meet you.
Oh yeah. Oh, sorry, everybody. There's a typo. Question 4 really goes to the options under question 5.
I was confused.
Yeah, that was a typo. Sorry about that. So when you see question 4, the choices are down there under question 5. Thank you. Yeah, the answer to question 5 goes with question 5.
So basically,
Oh, yeah.
I don't get it.
Everyone's going to get question 5.
There's some in there. Yeah. Sorry about that.
That's where they go.
People just supposed to be reactions.
All right.